Thank you for joining me to complete the 2-hour required teacher training on dyslexia. We will review the New Jersey dyslexia laws, the definition of dyslexia, the neurological impress of dyslexia, and look at the research that led us to understand more about what is going on in the dyslexic brain, some issues with school related litigation, and research that has helped us guide our interventions. We'll also discuss some instructional strategies and accommodations, how to write goals and objectives for students who have reading disabilities, and how to monitor progress to ensure success. As you are aware, New Jersey adopted new legislation in 2014. This legislation led us to the 2-hour required training for teachers and staff, the dyslexia screening, and inclusion of specific learning disabilities and dyslexia in the New Jersey Administrative Code. Also, for 2017, the New Jersey legislation has passed that October is Dyslexia Awareness Month, and schools should perform different activities to increase awareness and acceptance of those with dyslexia. Okay, let's start by looking at the definition of dyslexia. Many of you have probably seen this already, but basically what we're looking at is dyslexia is a learning disability that is neurological in origin. This means that we can see different brain activities in children and adults with dyslexia compared to the typical reader. So there's a neurological impairment involved in dyslexia. It is something that impacts the fluent word recognition and poor phonological awareness abilities. These difficulties often are seen in deficits in phonological component of the language, and often these children who have dyslexia have average to above average IQ scores. So their cognitive abilities in other areas are average to advanced. Secondary consequences may impact the reading comprehension, as well as reduced experience that they are getting from reading would impact their growth of vocabulary and their background knowledge. It's interesting how we've developed over the past few years, just gaining more knowledge and insight about dyslexia. But there are still many people out there who are under false assumptions about dyslexia. Often people will say, you're going to outgrow dyslexia. It's something that actually does not go away. It's something that the children and adults with dyslexia continue to face challenges as they go. Our goal is that we learn to create new neural pathways, in the brain to make better connections, and that they continue to compensate for the challenges that they face. Also, we often hear that dyslexia is a problem of visual perception, and the most common thing we hear are related to B and D reversals. Fact is that dyslexics have more difficulty at the phoneme level. Many children with dyslexia have what we call triple deficit dyslexia, where they have the phonological weaknesses, rapid naming, and that orthographic visual perception weakness. But it's not something we see in isolation in most cases of dyslexia. Dyslexia does affect boys and girls equally. There's no research that shows that boys are more affected than girls. And we can see dyslexia in any language, in any country, in any part of the world. It occurs in every language, even the ones that don't use an alphabetic script. A person with dyslexia can become a good reader, can become a fluent reader, can be a person who enjoys reading. With the correct systematic instruction, we can learn to teach our students to become good, strong readers. In review of the vast research that's out there, we can come to some consensus on what dyslexia truly is. We know that it's a neurological disorder that affects the basic reading and spelling skills and automaticity with sound symbol connections. It's often accompanied by specific weaknesses and cognitive factors that predict poor reading and spelling. These cognitive factors will be discussed in this presentation today. And we also know it is a lifelong condition, but with intensive interventions, we can reduce the impact of dyslexia. And many other abilities are often intact and can even be advanced in learners with dyslexia. Okay, so the statistics are a little bit tricky with dyslexia, and we have to take a step back and think about the implications of these statistics on special education. And we also have to understand that dyslexia is a spectrum disorder, which means there are many different levels and needs involved in dyslexia. So not every student who's diagnosed with dyslexia necessarily or should be getting special education interventions. Many children with dyslexia benefit from interventions in the RTI model, tiered level 2, or what we call basic skills interventions or supplemental support. So if you look at the school population, about 13 to 14% of our school population nationwide are identified as being eligible for special education services. Now, this includes all students with autism, communication impairments, specific learning disabilities. All the 13 classification categories are, making up this 13 to 14%. About half of these students who are identified are classified as having a learning disability, and 85% of those students have a primary learning disability in reading and language processing. So up to 15 to 20% of the population as a whole have symptoms of dyslexia. So that means in a classroom of 20, there is 1 in 5 have dyslexia. So of these 15 to 20% of the population, not all these students will qualify for special education, but most, if not all of them, will benefit from systematic explicit instruction in reading, writing, and language arts. Okay, we're going to take a look at the different brain images and impact dyslexia has on neurological functioning. What we'll talk about are 3 basic areas of the brain that produce language, where we connect the sound symbol connections and integrate sounds with their symbols, letter sound correspondence, and where we rapidly retrieve letters and words and images, and where we're storing those images of words. So these 3 components or areas of your brain are where the reading centers are. It's important to know that the brain is not naturally wired to read. We must learn to read. We are naturally wired to do many things, including talking, walking. Those are things that the brain naturally develops over time, and there's a developmental process. But the brain is not naturally wired to read. So all learners who are learning to read develop some type of patterning in their brain to acquire the ability to read. So here we see on the top is a typical reader, a brain imaging of what their brain is, where these activation centers are occurring. So your brain basically functions in a triangle. So information is coming in and then transfers to the other 2 areas of the brain. For a typical reader, as shown on the top, all 3 areas are being activated. However, on the bottom, what we see is just the Broca's area, the frontal lobe, is being activated in a child with dyslexia. So what happens is that information comes in and it doesn't know where to go. These are the students where it's interesting to watch, because when they go to read, oftentimes they'll look up at the sky, and as a teacher and educator, you're saying, why aren't you looking at the page? Look down, you got to read. But what's happening is that information is coming into their brain and does not know where to go. So by looking up, the children are almost waiting for that information to pass to the other areas of the brain where it needs to be transferred. So the information comes into the Broca's area, and those connections do not naturally occur in a dyslexic brain. Here we see another image of the left hemisphere. Now, the left hemisphere is where most of the reading centers of the brain are activated. What we see is an overactivation of the anterior language areas and an underactivation of the posterior reading circuits. So this just gives you another image of how these reading circuits are performing when we're providing students with dyslexia with phonological tasks, trying to get them to activate these areas. Now, what's interesting is when a child with who's developing some compensatory strategies on their own and not truly being remediated for dyslexia, their brain actually starts to light up in different areas, not the typical reader areas, but in different areas of the brain. So their brain even adjusts to those compensatory activities or strategies that a child learns to develop. So it just shows you with the brain how much neuroplasticity there is when we're training the brain to remediate these factors. We often see with interventions that these areas begin to even out and they are activating the three regions of the brain that need to. Okay, before learning to read, we use the part of the brain to recognize objects like a toaster or a chair. Then, as we start to read, we train the brain to recognize letters and words visually, sight words we start with. Initially, we see a chair. When we see a chair, the brain will see all angles. It'll see the left, the right, the back, the front, the bottom. We know it's a chair. But this doesn't work for letters. For example, we'll see your brain initially will see the letter B, and it will see the B as a D, as a P, and everyone learns to teach the brain not to transpose the B and the D. In a dyslexic brain, both areas of the brain are required to do this, are underactivated. So a child with dyslexia doesn't naturally have this developmental sequence in this part of the brain to not transpose these letters. So this is why, even though developmentally, say by age 7, B's and D's should be resolved, with a dyslexic brain, that could be something, B's and D's could be something that they struggle with for the rest of their life. Okay, it's also very important to know the family history when it comes to working with students with dyslexia. And often, should on all of our dyslexia screening, that should be one question that we ask the parents if there is a genetic history for dyslexia, if anyone in the family has had reading disabilities or been diagnosed with dyslexia. So strong evidence suggests that dyslexia has a genetic basis, but there is not one specific gene for reading. The different regions of the brain, as we just saw, are involved, and the family history is key risk for that indicator. What we also have realized through a lot of research that the corpus callosum is part of the brain that's very involved in reading, but it's also an area of the brain that is impacted or underdeveloped or underactivated when children are diagnosed with ADHD. So there's a strong correlation with a comorbid diagnosis of ADHD and dyslexia. About 25 to 40% of individuals with ADHD also meet the criteria for a reading disability. And the opposite of that, 15 to 35% of students who are first identified with reading disabilities also meet the criteria for ADHD. Okay, so let's summarize what we know. We know that certain parts of the brain are involved. We know that specific problems in cognitive, linguistic, and perception affect these skills. Oral language and reasoning skills are often more advanced in children with dyslexia. Early intervention, getting these kids early and providing intensive intervention is critical. Assessment and instruction must be planned and adapted for each individual, and it must be systematic and intensive. One-to-one or small group is what research shows to be the most effective. And teacher training, which you guys are doing today, is essential as well. There is a strong impact on these children emotionally, where they're frustrated, they have lower self-confidence. So research is showing that there's a very negative impact on their emotional state. And reading impacts IQ scores. So what we've seen through research is when we remediate and provide the intensive interventions in reading, and then we retest the child's IQ score, it goes up significantly with the correct interventions and development of skills. Okay. We also have seen other difficulties associated with dyslexia. Often children with early speech problems with articulation is related more to the phonological processing and phonological awareness. Often kids with a history of middle ear infections are not hearing the sounds at the developmental sequence, so they're losing the letter sound correspondence. They're losing the ability to be able to discriminate the sounds. Sometimes they don't learn the difference between certain sounds, and they often substitute those sounds in their speech, and they'll have the same issues in their reading and their writing. There's a strong correlation between immune system disorders such as asthma and eczema and dyslexia. So research has shown that kids with dyslexia often have a history of asthma or eczema. Oral language skills, we often see children lack logical structure in their speech, where you'll hear when they speak, wording their sentences incorrectly, or replacing pronouns is often a strong pattern we see with dyslexia. Numeracy skills, about 60% of the cases with dyslexia affect their ability to sequence numbers, rote count for the younger kids. And then as they get older, they have difficulty with calculation, longer computation problems that require sequencing and order. They lack those sequential skills to be able to do that. We often see high anxiety and stress related to children with dyslexia. Organization, poor sense of clock time, poor awareness of space, lack of time management. Since our children with dyslexia often have difficulty with sequencing sounds, order, left to right, orientation, these issues then impact their ability to organize themselves, so they require more support. Compensatory skills, many appear superficially adequate, and they may even score well on a DRA or on a theme test by using strong compensatory skills. But when you listen to the student read, or you look at their spelling, or listen to their fluency, those areas still continue to be deficient and need remediation. Mixed dominance. So sometimes we see students who have one eye dominant don't correlate the same hand dominance. So if you are right eye dominant, you tend to be neurologically, you should be right hand dominant. With children with dyslexia, we often see the opposite. They're maybe right hand dominant and left eye dominant. And what happens with these children, almost like two parts of the brain are not communicating. So one side of their body is telling them something and interpreting information, and the other side of their body is interpreting something else. So coordinating that information becomes more of a challenge for children with dyslexia. Early on, we can look at some predictors of reading, and some of the best predictors of reading skills and progress would be at a young age, their letter print knowledge, phonological awareness, rapid naming. Okay, so we're going to talk about the underlying cognitive factors that should be assessed and looked at to help determine what is impacting a child's reading development when they're struggling. First, obviously, is phonological processing, being able to hear and manipulate sounds within words, knowing that words are made up of sounds. Strong rhyming skills are necessary to develop reading. So if a child is deficit in that area, then that could be a weakness in phonological processing. Orthographic processing, visual processing, is the ability to look at different symbols, discriminate them, find ways to mentally manipulate those visual symbols and put them to form different objects. Rapid naming is very important. This is the ability to quickly look at sometimes pictures, colors, letters, numbers that are visually presented on a page, and under time constraints to rapidly name the objects or whatever item is presented. So for this, how we test this is showing a child, for doing rapid picture naming, show them a page of many different visual icons, like a little dog, a house, a bird, and then give them time to go through and rapidly name these. And then we time them to see how many objects they were able to name within a time frame. When children are not able to do rapid naming tasks within what their age and grade expectations are, this has a significant impact on their reading development. And we'll talk more about that later. But just keep in mind, this is something when we see a child struggling to read, we should be looking at their rapid naming skills. Processing speed is the ability to quickly do things under time constraints. And working memory is the ability to take information in your short-term memory and manipulate that in some way. Now, some kids, when we test them, we can find how significant their underlying cognitive efficiencies are impacting their reading. So what we look for is a double deficit or a triple deficit dyslexia. So with a double deficit, it's mainly looking at the three areas: phonological processing, orthographic skills, and naming speed, rapid naming. So looking at those three areas, where do they have deficits in those areas? So for a double deficit, it'd be two of those areas: phonological skills and rapid naming. So with this child, they are having a hard time hearing and manipulating the sounds within words. They may not understand that words are made up of sounds. They just hear a word as a whole part and not able to analyze it to the smallest unit of phoneme. They may not be able to do word games such as rhyming patterns or manipulating a word that's presented to them auditorily to say, okay, the word is cat, change the C to a B. What's the new word? They would not be able to do that, may have difficulty with that. And they would also have difficulty with that ability to quickly name and label different things. So for both of these, the phonological skills will predict word attack skills, so how they can apply phonics to synthesize and analyze different sounds to read and spell. And then their rapid naming would predict their word identification skills. Now, what happens with a child like this if we remediate the phonological awareness and don't remediate the rapid naming? They will still have difficulty with reading fluently. So we have to always consider there's still a deficit with rapid naming and be able to do different types of drills and activities to build that rapid naming skill. Okay, so a triple deficit would be that the child is having deficits in all three areas. So their ability to hear the sounds of the language, ability to use familiar sequences to read, and the ability to rapidly name different objects. So within our classrooms, we have basically 4 types of readers. We have the impaired decoder, but typical reading comprehension. This is your dyslexic kids. Typically, dyslexic kids, if you present information to them auditorily, or you ask them to do something that requires oral comprehension and take out the reading task, they can comprehend at or above grade level, but they cannot read the text. So this is your impaired decoding children. Impaired listening comprehension, but typical decoding. These are your children with language impairments. Oftentimes, these are children who are classified as communication impaired. They have real difficult time with understanding and using the language effectively. But they can read very fluently. They most likely have limited understanding of what they read and may be able to recall some facts from or literal content from what they read, but would have difficulty with the higher level comprehension type tasks. Impaired decoding and listening comprehension. So this is where a child has both dyslexia and a language impairment. Then you have your typical decoders and listening comp. These are the typical learners that are not having any weaknesses or are learning through your instruction. So with anything in education, we have to be aware of litigated matters, and we'll talk specifically today about litigation and dyslexia and what we need to know. Based on a research of the reasons for different litigated cases, we have a list here, but number 1 is lack of measurable goals and objectives, lack of data-driven decision-making, inconsistent program implementation. 1 year they're in Wilson, 1 year they're in Lindemuth Bell, and then they go to something else, or there's no program being implemented and followed at all. Lack of research-based interventions and curricula. So this is where the teacher created the lessons and the materials for this child with dyslexia. That will not fly in court. Evaluations are not comprehensive to do a full diagnosis and identification of a child with dyslexia. Lack of identification, eligibility determination, so the special education process is not being followed, and lack of teacher training. So between 1995 and 2005, there were 64 published Orton-Gillingham decisions. The grade levels of dispute were most frequently in the upper elementary area, specifically grades 4 to 6 in the litigated cases. In 39% of the cases, parents were requesting Orton-Gillingham-based programs, and the district would propose a similar program, so either a specific Orton-Gillingham or a generic multisensory approach to reading instruction. Of the programs requested, Orton-Gillingham was the most popular, followed by Lindemuth Bell. The most frequently requested remediations or remedies were tuition reimbursement to a unilateral or private placement, and districts won in 75% of the decisions, with parents succeeding completely or partially in only 23%. So these are cases that actually went through the whole due process procedures, and there was no negotiation or mediation involved where they came to some type of agreement along the way, whether a cost share or a different placement. These were the ones that the judge made the final decision.